Bismillahirrahmanirrahim. Ar-Rahman Allamal Qur'an khalaqal insan Allamahul bayan Ash-shamsu wal qamaru bihusban Wan najmu wash-shajaru yasjudan Was-samaa'a raf'aha wa wazal mizan Alla tatghaw fil mizan وأقيموا الوزن بالقسط ولا تخسروا الميزان والأرض وزنها للأنام فيها فاكهة والنخل ذات الأكمام والحب ذو الأسف والريحان فبأي آلاء ربكما تكذبان
Jazakallah. I welcome you all to the 10th hands-on colonoscopy training course. These courses are run in collaboration with Pakistan Society of Gastroenterology and GI Endoscopy and West Midland School of Endoscopy, Wolverhampton, UK. Our unit holds the unique honor of being the first one in this country to start these courses. And I know all of you who have opted for the course are working as consultants doing endoscopic procedures in your respective units via techniques which you have learned either directly from your seniors or from your peers. But the main aim of this course is for you to learn, or rather relearn, the technique of doing a safe and a painless endoscopic procedure. We have an outstanding faculty for the course. We have Dr. Waqar Ahmed, who is working as a consultant gastroenterologist at Manchester General Hospital, UK. Then we have Paul Hagen, who is a consultant endoscopist working in Mansfield Hospital at Nottinghamshire, UK. I welcome both of our international faculty guests. Our course directors are Professor M. Said Qureshi and Dr. Saad Niaz, two names who do not require any introduction. They were the ones who had come up with the idea of starting these hands-on courses in Pakistan. And alhamdulillah, we have finished the 5th hands-on colonoscopy course earlier this year, and ERCP, sorry, and 10th colonoscopy course we are starting today. So I'm sure this is going to be a great learning experience for all of you. I would now request Dr. Professor Said Qureshi to please come and say a few words.
Assalamu alaikum, everybody. Welcome you all to the 10th colonoscopy workshop, which is carried out to actually improve on your skills and to bring you up to par with international standards. I hope you will learn from this, practice this technique, and go on and teach others in your departments the same technique. I would like to thank Dr. Waqar and Paul yet again for being here. They have been with us from day one, and they continue to instruct on these training courses. Saad, of course, will be coordinating, organizing, and teaching you all. So I hope you learn from this and go on and teach others. Thank you.
Thank you, Dr. Said. I would now request Dr. Saad Khalid Niaz to please come and give a brief introduction of the course.
Bismillahirrahmanirrahim. Thank you, Sajda. It's been almost 5 years since we started this. Why do we do these courses, and what is the difference between this and you might have gone to other workshop or courses in Pakistan? This is proper hands-on course, which basically means that we actually teach you the proper method of doing colonoscopy and why is it necessary. in this brief introduction, I would like to know a little bit about you. That's what we do. And we want to find out what is your current level of colonoscopy and where do you think internationally people are. And we need to cover that gap. We need to try and be where everybody else in the world is. And that's the whole reason for being here. To do it correctly, safely, quickly, okay, and effectively. And obviously, there are a lot of people behind this. This is very strenuous. It's a very hard task for us. I'm sorry today we are starting a little late, and I'll take the blame on me because after the 3-day conference we are completely exhausted, but we'll try and catch up for the time that we've lost, about 30 minutes. So it takes a lot of hard work. Collecting 25 colonoscopy cases to be done in the next 2.5 days, because the first half you won't do anything. It's not easy. So there are a lot of people involved. Getting everything together is not easy. Sajda, Shahryar, the juniors, Dr. Misbah has just arrived. All these people really work hard for days to collect these cases. And really speaking, we don't get anything out of it unless we get a positive feedback from you saying, not just to show us, but we feel in the next 2-3 days we can see the difference ourselves. And sometimes the candidates will come and tell us, you know what, now I understand where I was going wrong. And that's it. We've all been rewarded. And that's the reward we're looking for. Okay? Now, before I go any further and tell you what you've already gone through some of the things, the USB has been given to them. I'd like you not to just leave it. Please go through it. It's important. And we don't have questionnaires here. We're not going to ask you MCQs and all that stuff, but we would be discussing. It'll be nice if you've gone through it for your own sake. So what I want to do is, we have 5 hands-on candidates. Doctor, we can start with the mic, the thing, जो भी आप नाम बता दें. I want the name.
Dr.
I want to know where you're working, and I want to know how many colonoscopies you have done. ठीक है? And what do you think your cecal intubation rate is? Okay? How many times do you reach cecum in your practice, that is? And what do you think is international good quality endoscopy जो लोग करें, उनका cecal intubation rate और terminal ileal intubation rate क्या है?
So my name is Dr. Mona Humera. I am working as an assistant professor in the Liaquat University Hospital, Jamshoro. I performed colonoscopy multiple times, but my cecal intubation rate is not very much successful. That's
Multiple
why
times is not good enough. How many times? When I was being trained, I could tell you exactly the number of colonoscopies on every day. I've done 35 today, 37 next day, next week it was.
It's a bit low.
So how many have you done exactly? Do you know?
It's a bit low, about 25 or like that.
Okay.
And my cecal intubation rate is not much good.
Okay.
Because I didn't intubate it independently, under supervision I performed.
Okay.
And that's why I come here to improve my skill.
Okay.
And the thing is that the working in the, although interior of the Sindh is much difficult than from here in the Karachi.
Okay.
And I think one should perform the colonoscopy, as you have said, painless and safely and quickly. So it's the international standard, I think.
Tell me something. What do you think? What is the units? You know, your supervisors and in your own unit. How many times in your colonoscopies are you actually reaching cecum? When the bowel prep is good, when everything is okay, how many times do you think you are reaching cecum?
In the Liaquat University, we have just started about a year ago. We have just started the gastroenterology unit. And in that unit, we almost performed, I as an observer many a times, but sometime assistant, we performed about 5-6 colonoscopies per week at least.
Okay.
And their cecal intubation rate was much good. They are about 60%, they are usually successful.
Okay, good. Right. And how much sedation do you use?
Because in what the thing is that we just perform in the such a difficult condition
No, no,
that
no. Answer specific.
okay sir,
We are not, we don't want long
Okay, sir.
answers. I want to know how much sedation
depend
do you
upon the person who is performing it.
What is the range?
So two consultants perform it without sedation,
Good.
and one consultant perform under sedation, and that was about 2 cc dormicum. That's or sometimes some
So that's it. You don't use anything more.
not
And
much.
the ones who perform without sedation,
That definitely patient is painful.
painful.
Yes.
So you have heard screams of colonoscopy.
Yes.
Okay, good. Can we move to the next, Dr. Sab? Doctor, Dr. Harris, you are the only observer. We've actually squeezed you in. So you're here in Civil Hospital. Quickly, how many colonoscopies have you done?
Yes, sir. I am doing colonoscopy for the last few years, actually.
Okay.
And I did personally, independently, almost 60, 70 colonoscopies. And I usually go into the cecum almost, but sometime with the help of my technician. I will not single-handed.
Technician.
Yeah, actually, when I am doing colonoscopy, I have a person who is assisting me. So actually, it is better to use a single-handed. But sometime when I stick up, so I will come on the wheels.
So it's a three-hand technique.
No, it's two-hand.
Well, the third.
Oh yeah, three-hand. Yeah,
When the second person comes in, we call it a three-hand technique.
Yes, then it will be a three-hand type.
Okay.
And I will sometime, as you know that if you are not in cecum, so the colonoscopy is not complete. Or up till now, it is, I think, mandatory to be intubated in the ileum as well, or you will pass from the terminalium. But actually, I have problem in somehow make a loop, and then I will be stuck up, and I will not. It is not easy for me to be de-loop.
What sedation are you using?
Yes, we are using a lot of sedation.
Okay.
Almost 4-5 milligram of midazolam and sometime 2-3 cc of kins.
Okay, that's.
But we diluted that kins.
No, I know that, but that's not too bad. Okay, 5 milligram is the top.
Yeah, and if I am going, and for example, if I'm stuck in somewhere and patient is screaming, and I will change all the maneuvers, like on the right lateral, on the on the lying position. But if I will not find any way, then I hold on. I abandon the procedure. And because we have 3 days in the endoscopy unit, so we can call that procedure from some other time.
Okay.
Thank you.
Fine. What is the cecal intubation rate in your ward?
Almost 100%.
Really? Who's doing it there?
Professor Badafaya Zubairi.
Okay, good. So,
Sir, I am Dr. Khurshid.
are you recording the intubation rate? Have you audited your colonoscopy at all recently?
Actually, it's not audit, but we have recorded all the endoscopies.
I am Dr. Khurshid Sammo, a general surgeon. I happen to work in a colorectal unit with Dr. Amjad Siraj, and I started seeing and doing endoscopies back in 2009 when GI endoscopy suite was started in OT complex. I was the first resident helping out every consultant. I have learned from Sina Basina learning from various consultants.
Okay.
Never been through a course. So this was an opportunity I wanted to avail. I have done almost 1,000, in fact more than 1,000 colonoscopies as the number goes. My cecal rate now, and in the beginning was of course different. Now I can manage around 80% cecal intubation. We do sedations, most of them without sedations nowadays, because we have a limited recovery area and we don't want to pile up patients post-op. So without sedation, but then sometimes 2 milligram midazolam and 2 nalbuphine.
So when you're doing without sedation and you have, how many patients are actually uncomfortable when you're doing procedures?
There are quite a few, yeah. There are quite a few, but
So
then when we feel that it's causing pain, or then we start giving it.
Okay. So how many patients in your practice, if you have a list of 10, how many of them would you end up giving some kind of pain relief? Or how many of them do you hear telling you that Dr. Sahab, pain ho raha hai mujhe?
Sir, we have once a week list, what I am involved in. And in that list, we have around 10 to 15 colonoscopies. And we...
And how much time do you have?
Sorry, sir?
How much time, what time do you start and finish?
We started around 9
And finish?
and finish up at around 1:32.
So 5 hours.
5 hours.
5 hours you've done
We have
50.
we have two tables, and we have 3 scopes, lower scopes. So we do manage like that.
Okay, and it's just one person doing it, or you have
No.
more than one?
2 persons, me and Dr. Amjad Siraj.
Amjad ji karte hain. Okay, good. Right, and next please.
I'm Dr. Imran from District Karak. I'm working as medical officer in TSU hospital, and I'm practicing as a gastroenterology in private at the evening. And I did around 100, 150 around. But
100 and 150 is 50
around
apart, 50%.
And seeker intubation rate is not good, because I face difficulty in looping and delooping.
And sedation?
Sedation use midazolam or nalbin.
How much?
Midazolam 3 milligram around, and nalbin half injection.
That would be average, or that would be the lowest?
Average. Average.
Okay, and where did you learn yourself?
I learned. I did my training in Hyderabad Medical Complex, but there is no concept of teaching to the juniors over there. We learned from our senior how they're doing, but never they taught us how to do.
So you're not allowed to do a case
No.
while he's standing and saying, okay, do this.
No, there is no concept of it.
Okay, right.
My name is Nizar Khan. I'm from District Swat. Up till now, I'm running my own clinic, and up till now I have done almost 160 colonoscopies. But independently, to be honest, I have never been gone to the CECOM. I have difficulty, especially in the sigmoid, in the splenic, and mostly in the hepatic flexure. And routinely, I'm doing upper GI endoscopies independently, and the lower GI endoscopies with a mentor, Dr. Anisul Haq Saab, in a private setup there in Swat Medical Complex. And we are usually giving midazolam as a sedative drug, almost 2 to 5 milligram routinely. Yes, sir. He is a very good person, and he has told me about you as well, sir. Yes, sir.
Okay.
Yes, sir.
There's one more left, right? Dr. Mujib Abbasi.
Hi, my name is Mr. Abbasi. I did my fellowship from Ireland, worked in the Republic of Ireland for 8 years, moved to UK for a couple of months, then decided it's time to go back home. So I'm working as a consultant laparoscopic surgeon, general surgeon in Liaquat Medical College, Jamshoro. Before coming here, I have done more than 680, I think, on my logbook. Initially, I attended Professor Kusheri's course in Dundee for doing the laparoscope, then was thrown into the dog's den, and as a surgical registrar, you have to finish the list for the consultant. So there I was taught how to do it. And in LMC, we have an independent laparoscopy unit. We do our own. I do independently. But because of the different constraints, we don't get too many endoscopies, especially colonoscopies, each week. We do 5 or 6 each week. I use 2 to 4 milligram between the age of 20 to 40, and above that one, because they are very thin and frail people, so I prefer to do around 2.5 or 3 milligram midazolam. Or if there is a kid who's 11, 12, 13, 14, then I prefer to use propofol as anesthetist being there, so that it's comfortable. I do here in last 5 years, I have heard 2 screams, and touch wood, no perforations as yet. But then the rate of success in Ireland was around 80, 85. Over here, because the people don't follow your instructions to clean the bowel or all those things, so I would say around 75 plus is the.
The success you think is low because of the bowel prep. So take the bowel prep out. How many times do you teach? If you have good clean colon, how many times do you reach cecum?
I would say more than 90%, 91, 92% I would reach the cecum.
Okay. Great. So we now know where a lot of you stand. It's important for us to know where we are, some of you are very experienced. 1,000 colonoscopy, to be honest, means that you shouldn't be on this course, realistically, because if somebody has done 1,000 or 600 colonoscopies, then this is a basic hands-on course. But you'll learn, hopefully in the next 3 days, there are a lot of things, or at least a few things, that you were doing, or actually making things difficult for you. Or you were doing things without understanding, sometimes correctly or sometimes incorrectly. But hopefully we'll give you concepts. Okay, what is your cecal intubation rate, Paul, if I may ask you? 96.5. That's lifetime.
Yeah.
And if you were to take the strictures and the bad bowel preps out, what would you be looking at?
96.5.
96.5. And what would your terminal ileal intubation rate be?
When I want it, I get it in 97.2.
So terminal ileal intubation, when he wants it, gets into 97.2%. So we've got one person, this is lifetime. How many colonoscopies have you done, if I may ask? 60,000, 70,000?
73,000.
73,000 colonoscopies. Okay. Oh, sorry. Paul, what's your sedation average?
Average sedation rate is 0 in 78% of the cases.
And if you were going to use sedation, midazolam and whatever you use, what is your sedation?
0.5 to 2 in midazolam, and fentanyl 25 to 100 depending on age. Fentanyl I will use in probably 15% of the cases.
Okay. Vakar.
Lifetime colonoscopy numbers, I think, would be around just over 10,000. Average would be between 95 to 97%, and cecal intubation rate. Midazolam, I think around average would be 1 milligram gross average. Fentanyl I use from time to time, about 25 milligrams would be the average. Most of them, majority of my procedures are without sedation.
Okay. Myself, I've done probably about 7,000. I've done less than both of them because since I've come back here, I don't do more than 5-6 colonoscopies a week. I don't get to do them anymore. Okay, that's one of the reasons. This sedation that we use would be 1 to 2 milligram on average. Would be probably maximum 2 milligrams of midazolam, if I would say less than that. And we use skins usually 1 to 2 milligrams at the most. Terminal ileal intubation would be very similar to what Paul and Vakar have. When I want it, 96-97% time I'll have it. A slightly different approach than some of the people working in Pakistan is that I tell all the ones who have worked with me that go to terminal ileum and I'll accept you've been to cecum. Okay. Because you see, the reason why I say that is when you need it, the reason why we have these high terminal ileal intubation rates are because every time if you're trying to get into it, you will be able to get into it when you need it. If you don't try, when you will need it, you will not get good results. So I think it's my practice. I almost always want to get into terminal ileum, except for if I see it's totally unnecessary and I have a long list, then then maybe I will leave it. So this is where the world is. If you were to take some of the reasons out, the cecal intubation rate in both of these guys would be 98-99%. I can tell you. This is all comers. Now that's one aspect of colonoscopy, reaching cecum, pain-free. Third is, why are you doing colonoscopy? We need not miss anything. Reach to kar liya cecum, we've been through the cecum, but if we miss something, then the whole colonoscopy. So obviously then the third thing is that doing effectively, making sure you've seen. And for that, when your withdrawal time is important, and we'll discuss all that. Now, it's very interesting. I hear, when this is the 10th course, so we are now used to it. We hear a lot of people tell us that they've got X numbers, or they can do this and they can do that. And then when we actually, when he asks you to do the actual case, we realize that there's some basic concept issues. So we will start from the basics. We will not treat you as if you're seniors, and excuse us for that, because some of you are seniors, but this is a basic hands-on course. So when somebody is applied for this course, he is telling us that he wants to learn the basics. ठीक है ना? So I'm apologizing beforehand because some of you are obviously senior. So if you feel something is very basic, just swallow it and ignore. Okay. What are the general indications for colonoscopy in your center?
Bleeding per rectum. Bleeding per rectum.
Ji.
Thank you. Bleeding per rectum and...
So anybody who has blood in stool, you would do a colonoscopy, regardless of age?
No, sir. In the old age, usually in the old age, otherwise first.
So if somebody comes to you at the age of 25 says, I have blood in the stool.
So first we exclude the hemorrhoids in the young age cases.
Okay.
And second indication is anemia, if iron deficiency anemia. And in the cases of the surveillance of the inflammatory bowel disease, or if we suspect that the patient is suffering from the inflammatory bowel disease, then, and these are the usually cases we found, because we usually didn't, IBD ratio.
So blood in the stool, anemia,
Yes, sir.
obviously where you're suspecting inflammatory bowel disease. Anybody wants to add anything?
Change of bowel habits
Change
and
of
weight loss.
change of bowel habits and weight loss, correct. Just a discussion. Blood in stool, find hemorrhoids. Do we stop at that in your practice?
So if the patient is a young age patient, we usually stop what our practice is.
Okay.
But sometimes if we have got some alarming symptoms or the weight loss or like that, these type of things are there, then we perform the colonoscopy.
Okay. Would everybody agree with that? I don't know if everybody would agree with me or not, but in my book, hemorrhoids does not exist. Even if it's, no matter what, especially in this country, young people present with rectal cancers. And I have seen them being treated as hemorrhoids. They do have hemorrhoids. But because hemorrhoids were seen and never a scope was put, I think the least we should do is put a sigmoidoscope. I would not stop at anybody who's seen blood, and this is my practice, and I'm not saying it's correct, this is my practice, that I will put a scope. You don't have to put a colonoscope, you just need to put a sigmoidoscope, but you must look at the distal colon. That's what I do.
My practice is do left side flexi-sigi or left side
Flexi-sigi
colonoscope,
is going to be
just
left
to
side.
be sure that that's the only reason, hemorrhoids, nothing else.
Okay, so you are fairly well versed with indications. We have some lectures. This course, first time we've cut down on lectures. So what will happen is, in between we'll be asking you questions and bringing up discussions, like we need to discuss a little bit about sedation. We're very happy to see that you guys are not using a lot of sedation, which is very good. I think the less sedation you use, the safer it is. And it's very important to ensure that you have flumazenil in your unit if you're going to use midazolam, and if you're using KINS, then you should have naloxone as well. Those two should always be there. Long expiry drugs can be taken. You probably need it maybe once a year or something like that if you go high. But if you're using 2 milligrams or 3 milligrams, it's very unlikely, unless you use it in an 85-year-old asthmatic or a chest patient, it's unlikely that you probably need it, but it's always safe to have it. Obviously, if you're going to use propofol, then like Dr. Saab said, we should have the anesthetist with us. So we will touch on some of the aspects as we go on. And Sajda, over to you now. I think we've covered up 15 minutes. I will not thank now because we have this thing about thanking a lot of people who are behind this course. But the chief course and person is Dr. Sajda Qureshi. She does everything, so all credit and discredit to her. Thank you.
If anything goes wrong, it's Sajda's fault. Sharia किधर है? Oh yes, Egypt गया ना? Mother. बेटा भाई.
I think because of my practice of bleeding PR and colonoscopy, I can be accused, I'm sure accused of doing a little bit more. But then because I do less otherwise, I would not be doing a 25-year-old presenting with diarrhea. It was clearly IBS, putting a scope, and I've seen patients who've had four. But on the other hand, having seen young patients presenting with rectal cancer much more than what I saw in the UK, I have changed my practice and I would tell my patients, even if you've seen a drop of blood, I don't care, but I will only treat you if I've seen at least up to your sigmoid. Once I've seen up to your sigmoid, then I'm relaxed. Until I've done that, because I have seen a few rectal cancers and that's completely changed my practice. I don't want to miss even one.